What I'd like to say to everyone is hello, and thank you for joining me to take this opportunity to talk to you about contemporary basics of enamel care. My practice is located just outside St. Louis, Missouri, a very suburban setting, and we have the pleasure of seeing some great patients. But just like you, we are challenged every day with mouths, teeth, and lives that change in response to the environment, habits, or health. And as you can see here, this slide, I like to assemble this because to me it portrays what Ben Franklin said, which is an ounce of prevention is worth a pound of cure. I do believe he was speaking directly to the dental profession when he said that. Currently in the United States, women live to an average age of 81 years of age and men to 76. We must take care of these patients dentally for their lifetime. And with that said, we must commit to becoming more keenly aware of this emerging and ongoing role in our profession to promote enamel therapy and wellness for a lifetime. We need to embrace, of course, a more current understanding of what tooth enamel is and does, the structure of it, and the treatment options that are available to provide nourishment and longevity for patients. Times are changing, and gone are the days basically of what calculus removal when patients would walk in and it was just not about periodontal therapy. And as you can see in this patient here, this is back in the time where we did quadrant scaling, and you can see this picture in intraoral camera view clearly illustrates how this patient presented with having the need to have some gross debridement as well as some very serious periodontal care taken, and it was given. And it's remarkable the patient even returned because, you know, most patients, and if you've been in practice long enough, you realize that this was probably not the best of worlds for them when they left the office because they felt one side was somewhat probably tender and the other side was still probably pretty messed up, so they needed a lot of help. So we've really changed a lot from where that thinking of just periodontal therapy and taking care of enamel in that fashion is and was. So here's some questions for you and how things have turned around, and I'm happy to say too, when you look at a patient like this, what are you doing for an enamel care and therapy program within your own practice? And I'm happy to say this patient fortunately has stuck with our practice and has gone through the time and the change of where we've treated enamel just externally and now subgingivally, and now we're going into maybe even remote, more microscopic natures and understandings of what the enamel structure is. So does your practice promote an active periodontal therapy program? And more importantly, do you have in place protocols that recognize enamel health? Are you working with your hygienists or your assistants? So that's exactly what we're going to talk about right now and discuss through this program about what's available, what's out there, current concepts, and more importantly, some great products that you can incorporate within your practice and within your hygiene team and restorative team to blend together to bring the wellness to your patients. Taking a little bit closer look, we're going to understand that carious lesions really do not develop rapidly. Other than erupting teeth or in cases where there's hyposalivation, where you don't have enough salivary function, carious lesions really take about 3 to 4 years to become cavitated. And these are just closer up views to get your eyes sighted on what you need to start looking for. Basically, when you're looking for cavitations, that's going to give the clinician a unique opportunity to say, hey, what am I going to do and how am I going to treat that? But before that even happens, we have a better view, and you look at the top slide to say, hey, how about we intervene with this and let's really prevent any more of this lesion forming and grab it in the initial phase. So these are just pictures to look at carefully and to start getting and grabbing a concept of early intervention. So this program really about what we're showing tonight and today is to share with you and what my practice does in response to a lot of these changes and how we manage this and how we've incorporated the hygiene side of our practice along with the restorative side to better educate ourselves and prepare ourselves for our patients and the needs and the care that they so deserve. This view here is basically what we see clinically every day, and patients present with outer lesions, and they also have plaque accumulation, white spots, and cavitations, not to mention probably what kind of therapy or treatment you're even starting to think about, and you need to decide what you're going to do and what you're going to commit to. So at what point in time have you decided within your own practice, what are you going to decide to say, is this a cavity, is this a cavitation, is this a lesion I'm going to watch, am I going to observe this tooth, am I going to try to remineralize this tooth, do I have a place This patient can learn to educate themselves. Do I have a setting within my practice in the hygiene setting that I can really work with them to embrace how they need to start to care and to better understand the changes that are happening to their enamel? So really, as a profession, we've got to understand a very basic principle that restorative treatment is not a permanent cure for caries. So the question becomes really, what is the risk of observing, replacing, or removing enamel? So as you can see in this case here, on the top slide, tooth number 18 was restored with a composite resin, while tooth number 19, the first molar, was observed from remineralization and therapy. And we were able to manage that and make that happen predominantly from able to use a early caries detection device, and we were able to develop a plan and get a case-by-case pattern of recognition and diagnosis to take care of this patient and to really actually see them 5 years later, and this is exactly what their mouth still looks like, and they're still in good care. We were able to keep and maintain them, and they understand fully what's happening. Not such the case in this illustration here. This patient is detouring down a very serious path of high risk of caries, and it's going to affect them for their lifetime. This is a young patient. He's 18 years old. He works in a restaurant, in a business that allows him to drink and sip soda during his shift, and we've had to really go in and modify what he is doing with his habits and really work with him and educate him. So we really have to have a great influence on this patient. Do you have a plan in your practice? Where do you start? How do you look at getting the enamel back on these teeth? Well, it's not even about enamel at this point in time. We've really got to get this disease under control. So my point being, we can really prevent a lot of this from happening at a very early age, and we need to do a better job as a profession. So here's some question right off the bat I'd like to ask everyone. What early caries detection device does your practice utilize? And I'd like to just kind of get an understanding of where your practice is at. And what I'd like to do is, there's a poll here, and if you would, if you're using one of these caries devices, if you are using more than one, please select the one that you're using the most. So we're going to go ahead and take this poll here. And again, what early caries detection device does your practice utilize? So I'm going to go ahead and conduct the poll, and if you would, you can go ahead and click on your answer, and then we'll be able to see exactly kind of where the audience is at and where we need to look at where our direction is going to be. I've been using a caries detection device. I currently use a Diagnonet, and I also use a Spectra, and we found these devices to be very, very positive within our practice. And I saw 2 patients, matter of fact, this afternoon that I was able to really create kind of a plan for them. So I think those are good ideas and good implementation of current technology. So I'm going to go ahead and close the poll here, and we're going to be able to show you here what we're finding out. And quite frankly, you can see here that the Diagnonet comes in at about 20%, and the Spectra comes in with about 2.5%. Caries scan comes in with about 2.5%. Other is 4.9%. And we're finding out about 56% do not use anything, and about 15% would like to. So I'm going to encourage you to go ahead and really move forward within your practice to try to get one of these devices. Do some research on them. They're really well intended, and they really can help your practice to grow and really to help your patients take that first understanding and step into what needs to be taken care of when you engage with enamel care and enamel therapy. So essentially, the objectives I want to cover are going to be understanding how oral balance affects your patients and how you can affect them and influence them. We're going to talk about caries and the current understanding of caries and the definition of what it is. We're going to talk a lot about what challengers do to the enamel, and more importantly, how we can nourish the enamel and really fend off the challengers. And last but not least, we're going to go and talk about how you can implement all this knowledge into your practice and really have a win-win for you and your patients. So what is the importance of oral balance? We've already established that patients are living longer. We've got to take care of them longer. We also know that we've got great tools out there to improve oral care, and we know that our science is advancing. We've got some good early detection devices, but what we do know for sure is that depletion of enamel creates two presentations. One is sensitivity, and the other is the caries potential. So oral balance becomes this challenge that we have to work with over the lifetime of the patient. And some of the management strategies that are out there now are basically based on interpreting the lesion activity and to see what, if any, future caries risk is present. We now recognize that remineralization therapy allows the uptake of the minerals into the tissue and, more importantly, into the enamel. And not only does that help to repair, but it helps to strengthen the porous tooth structure that we know as enamel. And also helps to increase the acid resistance. So this newly remineralized surface, this tooth surface of enamel, becomes less susceptible to caries and the repeated attacks on it. So it leaves that new surface in a more sealed, porous substance and subsurface underneath stronger and more resilient. And we're also coming to understand, too, the influencers of enamel, and we know that now calcium-based technologies are really emerging on the market, and they really help to promote enamel healing, if you will. So between early detection, which becomes very critical for this success to create stronger enamel, and if you can incorporate non-invasive lesion management with remineralization, you've really created, again, a very positive result for your patient long term. In our practice, we've kind of created what we call the oral balance checklist, and I've got a couple of things here, and I really would encourage you to establish these different balance points to understand exactly what is happening in the body. First of all, we go and we talk exclusively with patients about medical history. You need to review every time they come in for a recare visit or restorative visit. Is there any changes? Are you taking any new medications? Are you having any undiagnosed symptoms? This is interesting. The patient in the case I'm showing here right now, that she's had lupus, and she's had this for approximately, she's about 35 years old. She's had this diagnosis now since she was 24. And again, an autoimmune disease is going to affect not only the gingiva, but it's also going to affect her enamel, because it has definitely affected her level of saliva and her ability to clean and to keep plaque. So it's a very strong and important element to create a balanced checklist every time the patient comes in. These are very simple things to do, but they work, and they work very well. Next is the oral balance checklist of saliva and the tongue health. Again, another critical element. Don't ignore what happens with what the tongue or the saliva levels look like. Ask about dry mouth. Are they having difficulty swallowing? Do you need to sip something when you're eating? Do you have repeated times of drinking something in between meals? Look at their tongue. These are great pictures of illustrating healthy on the left side of the cases here over to the very far right side, which has a very, very dry tongue. But look at the tongue. That tells you the moisture level within the patient's mouth. It tells you the health. It's kind of the window into the body, basically. And they need saliva. We all need saliva. It helps protect the hard and soft tissue, and it promotes the enamel remineralization and demineralization. Plus, it helps in digestion. So very, very critical. A couple things right now that we know and we use within our practice. There's some good saliva substitutes out there and supplements. Certainly biotine's out there, I know. Xylitol, there's a lot of good rinses, but I really would encourage you and your hygiene department within your practice to really bring on some good education. Again, look out there for those products and push those out through your practice, because your patients will benefit. They need saliva to get their mouth and moisture level check balance, period. Another component we're looking at are carbohydrate and beverage consumptions. It's one thing to look at the enamel and to kind of assess the patient probably is drinking maybe more beverages that have acid or sugar in them, but they really need to own up to that too, and you really need to review their habits. And a good way to do that is maybe perhaps have them write down what they're eating and what they're drinking every day. And sometimes they really need to realize what they are drinking or eating. So that's a good thing to do and encourage. I know a lot of times we have athletes, it's hot in our summer in the areas we're at right now, and I know beverage consumption of sports drinks is really high right now. So we've got to really, again, monitor that, follow that up with brushing, flossing, water, you name it all. That's going to help get that off of the teeth so it doesn't have a chance to really attack the enamel. And finally, I want to talk, too, about medications. Really go through the checklist of what they're taking. Any kind of anti-anxiety, depression medications are going to certainly affect the patient's blood pressure, cardiac, even cholesterol medications, and more importantly, chemotherapy or any kind of radiation, especially to the neck or head. And that will definitely alter the ability of the patient to have saliva available, let alone changing the balance and changing that delicate nature in which we need to have those teeth healthier and the mouth healthier. The final thing we look at is definitely the quality of the enamel. And the assessment that we do on this is we look at several components we feel that we've arrived at that kind of give us an idea. And we'll share some pictures with us in just a bit, but we look at the luster, the color, definitely the surface texture. That's a very important thing. Is the surface texture shiny or smooth? Is it chalky or is it rough? And I think as you can relate to patients, and you see patients as well, you see the different presentations. And this can change within 3 months within a recare visit. It can change within 6 months. It can change within a year. So very important to notate all of these different presentations. Another thing to look at, existing defects, any enamel defects, hypocalcifications, maybe cavitations that you're notating, you're monitoring maybe with your Diadenet or your Spectre or any other caries device detection. And finally, you need to make sure that you look and notate and maybe even take pictures, photographs of gingival recession. That's critical too, because again, when that patient returns, we know that hyposensitivity can be created from the lack of enamel protecting that area because of the gingival recession. So what is the role of enamel? Right now that we know, tooth enamel is composed predominantly of about 97% weight of calcium phosphate mineral, and it's in the form of a carbonated hydroxyapatite. We call it HA basically. It's a crystalline structure. So you've got this hard, dense material that's a very important protective covering of the dentin. So obviously if you lose calcium or phosphate from that enamel, the result is going to be depletion of those minerals, and therefore you're going to get different lesions or cavitations or changes with that enamel or that enamel structure. And it's interesting too, it's taken some time, but I want to talk a little bit about when that loss of mineral happens and it's attacked by two main bacteria. We now have come up with the official NIH consensus, and it's been out there now for a couple of years, but bottom line is caries is a bacterial infection caused by specific bacteria. There are two main bacteria that do it. Caries is reversible. That's another big key. It's a multifactorial process. And to understand this, we talk to patients in the terms that when you have caries, or more importantly, changes happening in your enamel, you're getting attacked by an infectious disease. And I want patients, and I kind of akin this to pneumonia, where I say to patients, hey, guess what? Right now, you're having an attack in your mouth, and we need to improve this, and this is the way we're going to do that. And we set out their protocol. But they have to get a good understanding of what's happening here via this definition of what caries are. And this is the other thing too. The caries is transmittable, and that's another understanding they've got to get clued in on, especially with mothers. If you have a pregnant patient and she has the ability to pass that down vertically and transmit that to her child, she needs to be keenly aware of that. So, with Streptococcus mutans being the principal organism that's causing this destruction, they've got to own up that they've got something going on in their mouth that they can prevent and they can improve upon, and we don't want to let it get out to that last step of that cavitation process. We can back away from that, and by changing perhaps improving the saliva or the oral health care, and by making the environment better, we can definitely control what goes on, and we can prevent that demineralization or that caries or that cavitation that starts to happen. A couple of little facts I want to show and share here. This is a little poll that was done by the cranial head neck research area, but they brought out a poll, and they showed here, which is very fascinating to me, that right now when you look at children, adults, and seniors, the percentages of caries within those age ranges is really dramatic. In children, 48% of children in their primary teeth have one cavitation. That's pretty dramatic. Adolescents finds it the number at 59%, and that's in their permanent teeth. And then when you go on to adults and seniors, those numbers rise up equally to 92% of adults or seniors have at least one cavitation. So you can see here, this is something, if we know it's preventable and it's infectious, we need to do a better job at it. And we can't, because we have the ability now to do that. Kind of diving into what happens with the enamel and how it's attacked, plaques itself against it. I don't want to go into too much to what the biofilm and all the dynamics that occur around that, but bottom line, this is a closer look at what happens on and below the surface of the enamel. The lower left picture illustrates what happens with the demineralization process. Going over and moving over to the lower right picture, you're going to see here that fluoride in saliva will help foster that remineralization process because of their protective factors. And again, we talked earlier about when patients don't have enough saliva, or they're not getting perhaps the habit of maybe drinking too much bottled water, they're not incorporating fluoride, or maybe doing a fluoride rinse, they're losing that protective value of what that can offer. So really critical. Fluoride is definitely one of the best defenses against dental caries in children and adults. And you know, the highest concentration of fluoride is going to be found on that outermost layer of the enamel. So it's very important. It helps to really build the apatite structure of the enamel and the crystallinity of it, and it has a profound effect of increasing the structural stability. It makes it much stronger to the fluoroapatite type level. So very critical there. Saliva, on the other hand, helps to function as more of a lubricant and a cleanser while it's protecting, and also buffers those acids that are the onslaught of what we have to prevent against all the time. So we don't want to lower that pH. We want to keep that pH around a certain level that's going to be more protective. So really critical, again, to have the fluoride in the saliva be able to reach that surface so that we can prevent any kind of cavitation or any kind of changes that are going to occur happen. On a very mineral level, you can see here now the goal of the dental practice is really to, again, make sure remineralization is happening. And this is a very dynamic process that's going back and forth in the oral environment. You've got calcium and phosphate leaving the enamel rods. Meanwhile, you can, on the other hand, you've got calcium and phosphate and saliva pushing back into those areas and the surfaces on the teeth that have porosities that have been opened up. So again, the remineralization therapy is that phase that's going to lead to that uptake of the minerals in the tissues, and it's going to strengthen them and increase and make that much, much better and also much more resistant to the acid attack. So again, the rearrangement of how these minerals happen and how you lay those onto the teeth and the tooth surface of the enamel is really going to be the benefit for the patient. A chart that I've kind of created here to understand a little bit more importantly how this works is the dynamic process that's going to happen between the remineralization and the demineralization. So you can see the factors here that influence things either way and under either category. In demineralization, obviously, if we have a higher bacterial rate, we know that we're going to have more demineralization we have to fend off. If we have lower salivary function, dysfunction, again, that's going to ring a bell to say, hey, we've got to really get some replenishment in here to create more buffers. On the other side, remineralization, we see that saliva and the remineralization agents, as well as a very effective diet, can really make a very, very important effect on the teeth. So again, we want to have a win-win that's dependent on all these factors on the oral environment. And many of these, as you can see, are very, very dynamic in the factor that we can control what's happening here. Kind of relaying this out to more educational level for our patients too, and we share this slide with them to make them understand, but we have protective factors and we have pathological factors. And under protective factors, we see here that salivary flow, again, is at the top of that list. Very, very important. We need to also look at what kind of fluoride and calcium and what's out there to help deliver that, to keep that surface and those porosities intact. And then again, on the other side, if you look at pathological factors, what happens when we start to lose that balance and that tipping, that scale starts to drop down to that end, the caries rise. So it's very, very important to create strategies that benefit the pH level so they can neutralize the biofilm and promote more of the healthy bacteria in the biofilm. That's going to help drive the remineralization factor. This is a slide here that I really want to share with you so you can start to understand what active lesions look like and what high risk starts to look like in a patient. So kind of going back to that texture and chalkiness and those definitions that I was sharing earlier with the oral balance checklist, taking a closer look at what enamel looks like when a patient comes in who has a lot of challenge going on. These are active lesions. And you can see here on this slide we've got a lot of white areas. We have chalkiness. The enamel looks rough. The enamel looks very porous. I like to try to compare this to a very dry sponge. That way patients understand what a sponge is porous, and if it's dry, it needs to be nourished. It needs to have more moisture. So therefore, they kind of get a better understanding why they need to, again, replenish maybe saliva, perhaps maybe do a better job of fluoride rinsing, maybe a better job of brushing. Sometimes it's very simple things like that that can make this turn around, but again, that's the onslaught of what active lesions look like. On the reverse, here's a patient who is now in very active remineralization therapy. And you can see a totally different look. There might be some white spots, but now they're turning more to brown. And we know that the enamel surface is becoming smoother and harder. The fluoride and the calcium are working in that biofilm up against that enamel, making it stronger and more resilient. And it becomes a smoother surface as well. So much shinier and much harder surface. Again, that's working. So you can see the differences between active and, again, inactive. There's a term out there that many of us have now been recognizing within our practices called CAMBRA, and essentially it is caries management by risk assessment, and it is definitely becoming the standard of care. It creates definitely a pattern of recognition within the practice of what changes are happening within the oral environment, and more importantly, it helps you to establish, I think, protocols that you can implement within your practice. So extremely important to start looking at this literature that's out there. There's some great stuff that's being done on the West Coast, some good stuff that's really just penetrated our country with really good ideas that have come across that say, hey, listen, we can start now to take and assess and create a risk level for a patient. We can determine where they're at, and now we can get a plan to help them implement and maintain their oral and optimal oral health care. So that's very, very important. Essentially, this is about managing the risk factors, and CAMBRA helps us to do that. So I encourage you to do that. I'm not going to go into great length about it, but it's a very great system out there. Look it up, check it out, Google it, and you'll learn more about it if you don't know a whole lot. But there's some great literature on it. Two things I want to kind of bring out, and these are very, very important, again, assessments. And we'll talk about resources that we use within our practice too, but there's a lot of good things out there right now about how you start to rank patients within the CAMBRA system. These are environmental factors that I'm listing here, but you have a low risk, moderate risk, or high risk. So if your patients, say for example, are falling into an area where they are taking medications that reduce salivary flow, you can see there they fall into a moderate risk category. Even patients who have an eating disorder using tobacco products, again, they are a moderate risk. If they've had a family history of carious lesions in 7 to 23 months, a moderate risk. So quickly you can start to assess what's going on with that patient so you can start to develop a protocol. Following that up, you have your clinical risk factors. And these are things that you see within your patient when you're assessing them. And very important, again, just like we talked earlier about looking at the enamel and that oral balance checklist, you have these different clinical presentations that you help arrive and maintain some kind of care and some kind of protocol and some kind of therapy that patient can leave with, and you educate them about that and make that happen. So again, really good stuff, but look and create your own kind of protocols, and I encourage you to do that because that really is where I think you're going to start to grow your recare practice, and your patients really will benefit because you are taking the time to really educate them and move them forward, and you're going to keep their teeth through their lifetime. I know that everyone says prevention is key, but it is really true. Some of the frontline defenses that we're using right now currently are prophy paste, obviously. We know about fluoride. It comes in a lot of varieties now, varnish, gels, and foams. Of course, sealants have been around for a while too, but again, all of these target to build the enamel and prevent that biofilm negativity where you drop off that pH level, and then you've got a series of attack on the enamel, loss of minerals, and then you're going to get cavitations or changes. So really important to understand these are good frontline defenses. You can see there's some great brands out there. We use a variety of brands within practice. We like to use obviously flavors that are more pleasing in their flavors or their tastes because patients obviously respond to certain things. But again, you can kind of see what works out there, taste some of these products and see what's more pleasing and put those into your practice because of those reasons. And I think you'll have a win-win with your patients. Very important. Kind of interesting, too, to note, one of the big things that's coming out and really being, I think, pushed to the forefront are the different types of fluoride varnishes. And that code, I think, is going to be changing with the U.S. From what I understand, it's 1206, but that's going to be moving up to 1208. So make sure you make that changes, but within your coding system. But again, all these different supplements here help to make and benefit your patients and bring them into a better care level. I do want to talk a little bit about sealants because this is an interesting thing. I think we can do better as a profession, and essentially this slide is showing and sharing with you what percentage of third grade students across the United States are getting sealants. And this is kind of concerning to me because I think if you look at the numbers and you see what state you're in, at the very highest level, there's only a handful of states that are greater than 50%. So sealants, we know for a fact, work. So I think we need to push out more education. We need to have a better reach and a bigger reach for what we're doing with our patients. So it's definitely achievable. We just have to go out there and make that discussion happen, I feel, and really be in the forefront to push that and make that happen. Briefly, I want to talk a little bit about home care, but then I want to go into clinical cases so you can see here. Really important, I think, to start entering that conversation about xylitol. And this has been a wonderful product. It comes out on the market. It's a 5-carbon naturally occurring sugar that's not metabolized by the bacteria, so it helps to stop the production of tooth decay causing acid. So it is a really great benefit. It comes in the form of gum, lozenges, or rinses. We really try to promote gum chewing because patients seem to feel, I think, a little bit better with knowing they're being active in that. Essentially, we tell them to go ahead and chew gum 3 to 4 times a day throughout the day, especially after they have eaten. And I think regular use of xylitol products definitely helps to gain a hold on the dental surfaces and strengthen that enamel. And it's a critical element in enhancing remineralization with your practice. So really try to promote xylitol. I think it will help. And there's, again, great products out there that help make that happen. You've got chlorhexidine rinses now that we know are very important. There's several good ones out there. Get on the market. Go out there and grab what you think tastes the best and what patients are going to be most compliant with, and I think that's what you arrive at. But chlorhexidine is a great antimicrobial rinse. It helps to reduce that bacteria that's both anaerobic and aerobic. So it's a very important, I think, adjunct to reducing the caries onslaught. It's also very important that you understand how it can be used for probably usually about 6 months, and it can really help reduce and balance the bacteria within the mouth. So it's a very, very critical element, again, to incorporate in your armamentarium. The last thing I want to talk about here on this slide is essentially prescription fluoride toothpaste. Again, that's something that we do dispense within our own practice. There's several that are out there, but predominantly they are usually around 5,000 parts per million. You use this daily. Make sure that patients understand they do not rinse after they use these toothpastes. Rather, they spit that out, and whatever remains on their teeth stays there and it works. And we really promote this, especially at bedtime. I think it's critical that patients go ahead and use that on a daily, regular basis, especially at night. I think one of the newest and best things out on the market is ACP. And we know this to be amorphous calcium phosphate. Essentially, this has been around for probably about, I think, since around 1991. And this technology is really critical because It helps to speed up the remineralization process. This is one of the best enamel nourishers out there on the market today. It is terrific. It takes the unstable calcium salt and a phosphate salt and delivers them, and essentially through the process, think about that porous surface again, that sponge-like surface of the enamel. The delivery system allows that ACP to precipitate literally on that tooth surface, and it just kind of filters in and creates a reservoir of calcium and phosphate ions over that surface, and it really helps to deposit a new mineralized surface. So it's really important. It hangs around in the mouth for 6 to 8 hours after you've been using it, and it really helps to fill the defects in, and it really helps to create a very solid, improved tooth surface. So again, if you're not using anything with ACP, look at this. It's a great product out there. It's safe, it's healthy, and it works extremely well. You can find it right now in Prophy paste. You can find it in fluoride rinses. It's in gels. It's even becoming now apparent in sealants, desensitizing agents, whitening agents, and also in restorative cements. So it's really starting to reach broadly across the dental field, and this is great because it's going to really help with patients' care and hypersensitivity as well as just enamel nourishment. So a great process. This slide here kind of shows you a little bit how ACP works. Essentially, you've got the calcium and the phosphate, and they're going to go in on the surface. Again, you've got a very porous surface. It binds up, creates that reservoir, and it just kind of filters in. And it just, think of a colander, if you will, and how things sieve through that. It filters in and levels out that surface and makes it stronger, and it really creates a newly strengthened enamel surface that now has to be attacked at a lower pH level to really have any kind of cavitation or microporosity to the point where it's going to allow that surface defect to maintain. So it really is a great agent, and it's great technology, and I know our patients are benefiting from it because they feel immediate change and immediate improvement once they've had or be treated with ACP, so we can attest to that. What are the benefits of ACP? Obviously, we right now know that it can remineralize. We've talked about that. But more importantly, it helps to strengthen that enamel and reduce the caries chance, like we talked about earlier, because it lowers where the pH value is that caries can start to happen. It improves the surface, and most importantly, we're finding out too that it reduces dentinal hypersensitivity. So those patients that you have gingival recession on, areas that have been challenged with any kind of gum exposure, root exposure, this is a great benefit for them. So it really helps to not only answer to enamel loss, but also if there is recession, any kind of dentinal hypersensitivity is a great thing. I really encourage hygienists to continue to review this current literature that's coming out about this, because this is one of the best, I think, products available to comprehensively treat their patients, and really excellent controlled studies that are out there right now with this, and super good benefits. I want to share some cases clinically about what we see within our practice, and I hope this is a pretty good view, but quite frankly, you can see this patient is what I would label as a low-risk patient. They have a good tongue health, they have good saliva present, good gingival health, very low biofilm. This is patient, I mean, when they walked in, this is exactly how they present in their practice. Nil to none plaque, they're flossing, they're doing the right things. And again, their teeth for their lifetime, to keep them in this realm, we have to continually educate and continually promote a kind of a cheerleading attitude. So what do we do for a patient who's got low risk? Within our practice, we're going to go ahead and advise them to have a 6 to 12 month recare. I want to keep any kind of xylitol gum promotion within their mouth and their oral balance, keep that going. We're going to do bite wings 24 to every 36 months. Obviously, sealants are in play there if we need to do that, and over-the-counter fluoride rinses. The challenge now becomes when you start to get patients who have a little more need. And here's a patient here that has a moderate risk. And the reason we've labeled her as moderate risk, if you look carefully in her mouth, you can see that she's had several crowns. 4 on the mandibular and 4 on the maxillary. And you can see margins now that are starting to open up a little bit. So we're going to put her in a moderate risk. We need to make sure that we're getting a fluoride rinse in her mouth. We need to make sure she's a little bit dry. If you can see there, I would classify her tongue health is not as healthy as it should be. Her saliva level is a little bit lower than it should be. We need to get that glossier, more pink, and more healthy. The way we're going to treat her is, again, bump up saliva substitutes, xylitol gum chewing. That'll help stimulate some saliva flow as well, and make sure that her oral hygiene is really in great care. And obviously encourage a little more bite wing and more recare visits. Here's another example of a moderate risk. This patient presented, and she's had very current recare visits throughout her entire life, but 4 months ago she developed a very severe bout of pancreatitis. All of a sudden her oral health changes. Her oral balance is off. She now has less saliva. Her tongue is more pink. Her gums are more pink. Or red, rather. She's got more gingivitis. Her biofilm has changed. She said her teeth felt sticky. And you can see here there's a different shininess to that enamel. So how are we going to treat her? Again, here's the moderate risk profile. 4 to 6 month recare. We're going to improve more bite wings because we're going to make sure and increase those a little bit to make sure that we're paying any attention to any enamel changes, especially in proximally. Definitely an active topical fluoride rinse, any kind of sealants, improve the saliva, increase that, maybe even do a saliva test, and really watch out for any kind of enamel changes because those are the kind of patients that are really tough. They're going to take more effort, and you're going to have to require more care and more education with these patients to really sit down and get them to where they need to be. This patient, obviously, I think we would all agree, is very high risk. They present the biggest challenge for maintaining any kind of good oral health. And this patient here is a really big challenge because of the decay level, and we've got to really work with him on his home care, his knowledge, his education, what's happening in his habits, and really become a key motivator for him to develop some kind of compliance that he really starts to own up to, incorporating these therapies daily. So this is a really big challenge, and I'm sure many of you see patients like this, and it's frustrating sometimes because you think, you know, you're doing a really right thing, and next thing you know, they show up, and before you know it, 6 months to a year later, they're going to start looking like this, or more importantly, they've had orthodontics, and a lot of changes happened after those things too. So again, watch that out and slot that patient into moderate to high risk. So what do we do for a patient like this? We're going to have them come back more often. Again, we're going to have more active bite wings that we're going to take and monitor graphically what's changing. We're going to be doing definitely a topical fluoride. We're going to probably incorporate even more fluoride varnish within their practice, or within their oral health care practice. Xylitol gum is going to definitely be our mints, recommended daily. We're going to incorporate chlorhexidine. And of course, go after those lesions, cavitations, and try to restore, hopefully try to get those into a level where we can really arrest what's going on actively within that bacteria pool, because it's really tough. I want to talk a little bit about dental hypersensitivity. So here's the other issue of when you're starting to lose enamel. And this is critical because right now we know 1 in 3 adults suffer from this. And it's really important to have a game plan when patients come into you and they show, you know, they love their white teeth, but then they smile a little bit bigger and broader, and you see all the gingival recession. So this is critical. It leads to obviously a very non-aesthetic appearance, but more importantly, the chance of erosion or the chance of caries becomes greater with patients like this. So we need to have a game plan and a protocol that really can benefit their aesthetics as well as their oral health. A lot of times you have patients that come in, they might have a high frenum, a muscle attachment, they could have thin gingiva. Orthodontic movement can cause some of these, subgingival restorations, obviously abrasion, periodontal disease, snuff use. There's a lot of different ways that gingival recession occurs, but we need to be keenly aware of when it starts to happen, measure it, find out the cause, and start to work with it. Enamel surfaces like this, and when they go on the dental surfaces, are a little bit different. Dental surfaces like to soak up any kind of fluoride varnish. So I will show you a couple clinical cases here of what we're doing to really benefit those surfaces to get them slicker and smoother and more resilient. So what we know about the root surface it is definitely more susceptible to demineralization, and it begins at a 6.7. What's important is if you can get that surface to be exposed to fluoride varnish and get an uptake, the progression of that uptake is quicker and faster, and it will soak up that fluoride quicker than enamel, and more importantly, it will drive down that sensitivity. So you now are creating a more resilient surface because you've soaked it and nourished it correctly. So I encourage you definitely to do enamel, or rather fluoride varnish on these areas, these root surface areas, because they're going to really soak it up. What do we see clinically? What do these look like? We have patients come in all the time, and you've got to arrive at, are you going to prevent this? Are you going to try to do some kind of non-invasive treatment? And can you arrest this? Can you do fluoride? Can you do chlorhexidine combinations? These are really tough areas, and a lot of times they're in areas that are aesthetic, and you have to think about what's it going to look like when you get the final restoration done. Obviously, if you can try to maintain and really keep that area and treat it to get it to remineralize, it's much better. And we made it an inactive lesion point. That's much better than having to treat it. But if you are going to, you certainly want to use smart materials like glass ionomers and resin-modified glass ionomers, comprimers to treat these. And I'll show you a couple pictures in a little bit about what we're doing with some of this. But you certainly want to convert that lesion from an active lesion into a inactive lesion. Again, you look at the surface, slick and smooth, you look at the brown, you look at the white surface, what's it doing and how's it doing it. Here's some restored root caries in a patient that we had recently come in, and quite frankly, it's not the most aesthetic appearance, but this is a glass ionomer presentation. You can see here on the buccal surfaces on 30 and 31, we had the challenge of having not only gingival recession, but root caries started to formulate right in the very buccal corridor there. So we went ahead and we placed 2 glass ionomer restorations. Are they the prettiest? No. Are they going to help fend off the disease? Because every time she rinses with fluoride, that's going to help store that back up again? Yes. So in my eyes, that's good treatment. More importantly, you know, a patient comes back later on, she says when she drinks something cold or hot, it doesn't bother her anymore. So that's a win-win in my book for good treatment. Here's another case. You see these every day. You got a patient, you got class 5 restorations, or are they really restorations? Do you need to watch them? What do you need to do? Well, you start to look at this carefully, and on tooth 11 and tooth 13, we have active decay. It was soft. And on tooth number 12, we have some abfraction. More importantly, we got dental hypersensitivity on all 3 of these teeth. So we went ahead and restored these now with a I use a basic composite here, and we did some nice class 5s and got a nice result. Again, lessen the sensitivity, but is that my first line of defense? No, I rather would have treated that patient with some kind of remineralization therapy, but you're at a point in time where now you've got active decay, we've got to make a change. So what do things look like clinically in patients? Here's a little boy that comes in, and he's got a jumbled mess in mouth of teeth. You've got teeth that are in positions that, quite frankly, he's not really ready for orthodontics yet, but more importantly, I've got to really work hard to make sure I can keep these teeth clean and make sure he can keep these teeth clean. So we're going to use products on him, and we're going to use methods on him that I want to say are going to keep him, what I call in the positive mode. He's going to really stay positive about his oral health care. He's going to feel good about what he's doing and how he's doing it. So essentially, we're going to use some prophy paste that has ACP. And in this case, we're going to use flavors, I think, that are very pleasing. They're going to have good rinsability. They're not going to have a lot of grit or a lot of splatter. And especially young kids, I think, akin to this, they like that. It feels better in their mouth. They like to have products that are not going to be, as in their terms, nasty or flavors they don't like. But here we're using the 2 Pro Total Access by Premier. We're using a great little prophy cup that you can actually remove the cup and then use a point then to get into all these little hard to get to areas. And you can see here it's really nice because it creates that total access. You're able to get into lingual areas, occlusal areas, subgingival areas, and proximal areas. And with one little gadget in hygiene, this certainly makes a big difference, and I think your hygienists really will appreciate this. I know that we like it. It works great around orthodontic brackets. There's a lot of great potential here for this device. So this is a nice little polisher. If you're not using it, I really would encourage you to get into and try one of these because they work really, really well. Another product that we're using more and more of, and I talked briefly about earlier, is definitely the fluoride varnish. And you can see here, this is Enamel Pro Varnish. Again, I find that enamel varnishes, fluoride varnishes, are really critical for patients that have definite porosities when they're in their enamel. This patient here had and has a kind of a learning deficit, and her ability to clean her teeth is not as good as what we'd like it to be. And to put a fluoride tray in her mouth is really not a good option because it gags her and it's very kind of intrusive. So here we are. We're going to go ahead and use just basic fluoride varnish, and we paint that on. And this single dose is perfect to use. Very, very pleasing. Patients like that. It works well. It spreads well. It stays on well. It keeps working after they leave the practice. It's just a good win-win. And again, we're using more and more of this. If you are going to use this, I would definitely encourage you to use the code 1208. That seems to work correctly for insurance submission. Great stuff. Really like it. It's less messy and all that kind of good stuff. Here's another great example of the lingual of some teeth that have just been recently cleaned. This is an intraoral camera picture. You can see here we're painting this on. Those surfaces, when they pop open, they tend to be a lot more sensitive. If you can go ahead and use this in that manner to create and cover that, that's going to soak in again to those root surfaces, those dental hypersensitivity areas, you're in great shape there. So again, a nice specific application of fluoride varnish in that method. With OrthoCare, I think it's critical that you're using some kind of, again, fluoride varnish. Look at the uptake. Look at what's out there right now. But Enamel Pro is one of our very favorites, just mainly because of how well it performs. It exceeds expectation. You got to get those brackets clean, and then you need to paint that stuff on and make sure they're taking good care of their mouths. And really, they can't brush enough when they have braces. And we tell them, orthodontic care really makes you drive up your oral health care in a great amount. So you've really got to go out there, use your product too. And if you select these kind of products when you practice, again, enamel fluoride has got to have all those other ingredients we talked about to nourish. So if it's got ACP, you're really giving the best benefit, I think, to your patients. And that's what we're seeing clinically. So good stuff. Here's another case here where we're using fluoride varnish. Another application we see is 6-year molar protection. Once and often we see patients that come in that operculum and the tooth is not quite erupted. We're going to go ahead and paint on a fluoride varnish again. We're going to coat that area until we can adequately access and isolate that to put a sealant on there. So very important again. It's interesting too to know that when a tooth erupts, it's not really fully mineralized. So this fluoride uptake is really great. And it's interesting, you'll have, over time, saliva will soak up that fluoride, and it'll add about another 10 to 2 microns of 100 microns of enamel over time. It'll incorporate that. So it's a very, very important addition into your practice as well. Here's a case that I do want to share because this case went awry. And this is a patient that we inherited who had some Invisalign treatment. She was never instructed how to take care of her teeth, and what she did was she covered her teeth, and so saliva never got on her teeth to help manage the oral balance with her mouth. So you can see this is quite a high risk and quite a difficult case to move forward with. So I'm going to encourage all of you to create a protocol that you consistently have patients do and perform while they're covering their teeth, whether traditional orthodontics or whether they're covering them with plastic. Have something in your game plan that you can share with them to really protect their teeth and do very well with it. Some resources that we use here, very important. I think you can go to the ADA, and right now there's some great stuff online. You can look at the different sheets you can print out. Right now they have caries risk assessment. They have these divided up per age. They also have on the left side here, you can see the risk for dental decay, and they go into great detail about different recession areas and how much when gingival recession starts, when it goes into dental hypersensitivity, and more importantly when a carious lesion then starts. So this is, again, all very, very good information to start incorporating and start creating a plan within your practice that you can consistently work with patients to get them on so they can start to balance their mouths and keep their teeth for their lifetime. Really critical. Another great source that I like to use is, again, I talked about the ADA, their caries risk assessment. You can write these websites down, but go out also, if you want to learn more about camera, go to the CDA Foundation absolutely incredibly important to see and read what they're doing. They're really setting, I think, a great message and a great foundation for all of us to start with and to really learn and to grow from and to really incorporate clinically every day within our practice. And the other website that I really like is the Missouri Dental Association. If you go on there, they have a Stop the Pop campaign, and they even have printouts that can list what kind of beverages your patients are drinking. Again, we have this readily available for patients, and it displays completely the sugar amount, the acid amount that's in every beverage. It talks about the pH level, and again, that enters the conversation that you can start to have with your patients to educate them about what is going on within their mouth and helps them to own what's going on. So really critical. A lot of good stuff that's out there right now. I think most importantly, clinical success is going to be what you find and how you partner every day with your patient within your hygiene and restorative sections within your practice. And to me, I think the win-win becomes when you see patients return and they do improve. And I know that's not always possible every day and every time, but you've got to work hard and you've got to commit to it because you've got to be developing an active oral hygiene program. And it's really, really critical. Prevention is going to create that enamel longevity like we talked about, and we all know that's really important. Early intervention. The sooner you can find some changes, that you notate those changes, just like that one first slide we saw there. Those enamel changes, discolorations, texture, surface, gloss, shine, brown or white. Write those things down. That intervention might make the difference between the patient having a tooth for their life, or maybe now we start to have to restore, so they go on to a different pathway. So incredible to understand that you can help manage your patients, but you've got to really enroll and partner with them to be a good partner. So really, really important. I encourage you also to have a very active program that you educate mothers to be, because again, they're the vertical transmitters usually for dental caries. So there's your educational moment where you can really make an impact on that baby or that child. And that window of time is usually between 0 and 36 months. So talk with them, get them on board with what they can do to get their mouths in great shape. That's going to help their child's mouth as well. And more importantly, commit to restorative dentistry that's using smart products. Get out there, get those enamel nourishers, get the ACPs, do the different fluoride rinses, commit to our low, moderate, and high risk different protocol levels and identifiers, and then that's going to be the win-win that you take forward, and that's going to educate your patients. It's going to educate you to keep on board and on track with everything that's going on with your patients. So that's just good dentistry. That's just good, I think, commitment to your profession and great commitment to your patients as well as yourself. That's great professional satisfaction as well. I want to thank everybody for joining me today, and I really, really wish you the best in your practices and the care for your patients. I'm going to take some questions right now, but this kind of concludes the program.